will have the weakness, and there is a fatigability of the phonatory muscles occurring in this phonostimulation. Either thyroid muscle or enteroretinoid muscle, or both may be affected in some patients. Every weakness or fatigue of
Yes, sir.
yes, okay. And here the thyroid and enteroretinoid muscles are both may be affected in these cases. There is early weakness or fatigue of voice will be present, and laryngitis with abuse and misuse of voice is the etiology. Those people who are having laryngitis because of abuse and misuse of voice, they feel more strained. That is why weakness when they speak in the people. These people, they complain unpleasant sensation at the neck and also in the larynx, in the throat. And this is more seen in cases of professionals like our doctors. See, doctors many times say, I feel I am fatigued to tell this patient, to explain my tone is decreasing. That is what we say anesthesia. And also, another job is the teachers. Of course, online is something advantage for the doctors, for us. Congestion and redness of the vocal cord margins will be there, and there is a tenderness of the staph muscles. When the patient asks them to feel the neck, they say that my muscles are giving pain, tenderness. Treatment is by speech therapy or vocal hygiene, and the psychological therapy has to be taken care. Next is the C. You are having a short notes, 4 marks or 2 marks question, dysphonia, plica ventricularis 1, and another one which I told you, functional aphonia. Here is spasmodic dysphonia. Here what is happening? It is normally it is an unknown origin. Mostly a neurological still has to be investigated. In the recent time, in the recent advances may give the etiological factor. The cause here is what happens. Vocal folds goes into spasm during phonation. Sudden spasm will occur here, and this is having 3 types. What you call adductor spasm, it is 81% will be here. Abductor spasm will be in the 17%. Some people they will have both adductor and abductor, which we call it as a mixed one. This spasmodic dysphonia is identified or described first by in the 1871, just imagine by the Trabe. It is a focal dystonia. Only part of the things will involve focal one that affects laryngeal muscles control during speech. Dystonia refers to a syndrome of sustained muscle contraction. Dystonia means it is a syndrome of sustained particular muscle contraction. Focal dystonia involves only a few localized muscles here. It is more common in the females, seen in 2nd and 9th, up to it is seen in a large, wide ages from 2nd decade to 9th decade, anywhere you can see. But typical age is between 29 to 45 years. That is adult age. Stuttering can be prevented by counseling these parents in early stages of the speech development. See, this type of dysphonia, we have to start at the early stages itself. Just don't leave the patient. And tell them not to overreact to child's difficulty. See, sometimes the parents show on stress they will produce on the child, which will increase the spasmodic dysphonia. Psychotherapy to improve his image as a speaker. See, you have to give, you can speak very nicely, give some lectures, you go on speak. This reduces his fear of difficulty in fluency. We already discussed 3 types. Out of that, adductor spasmodic dysphonia, which is more seen. There is voice breaks are due to spasmodic hyperadduction of the vocal cords that interrupts here in the phonation. Vocal fold closure interrupts phonation by causing strained or strangulated vocal quality. It is a strained or strangled vocal quality with an intermittent weak break will be there. In this adductor spasmodic dysphonia, the muscles involved are the thyroarytenoid and lateral cricoarytenoid muscles, which give more spasm with a predominant action here. The adductor spasmodic dysphonia, which is around 15%, voice breaks are due to spasmodic hyperadduction. Here, hyperabduction occurs. Sorry, this is abductor, which occurs hyperabduction, which interrupt the phonation. Patients have a prolonged breathy voiceless breaks. That means, as you see in the functional aphonia, which is a continuous one, but here these patients will have a prolonged breathy voiceless breaks. That means they will have abduction will occur and it is more prolonged. These are all things are observed more in detail after stroboscopy, video stroboscopy. The pitch changes and uncontrolled rise in the fundamental frequency of the vowels may make them sound as if they are in the verge of crying. Sometimes the pitch here changes here. There is no control in the fundamental frequency of the vowels, which you feel that the patient is also having some crying sounds here. In abductor spasmodic dysphonia, the posterior cricoarytenoid muscles are defected. These things will give more abduction, and these are the etiological factors for this type of dysphonia. We have to evaluate these patients by detailed history. This is done more with the help of speech therapist. Second, we have to do the video laryngoscopy and also the video stroboscopy, which I have mentioned here. And there are some studies which we are doing nowadays is the electromyography of the vocal muscles. That also is improved. Those are some people who work mostly on these subjects only, and they address this electromyography recent days. The weakness of thyroarytenoid and interarytenoid muscles, which we see in cases of adductor spasmodic dysphonia, what happens whenever there is a weakness of the thyroarytenoid is there, then what will happen? There is a bowing of the vocal cords. See, the vocal cords both are bowed, and you will see a semilunar space here. And when only the interarytenoid muscle is affected, then you are seeing a triangle here behind, and there is a thyroarytenoid, their vocal cords 2/3 is opposed, but only 1/3 is separated. When you see both the muscles are involved, even you see bowing and separation here, and this is what you call, you are seeing here, there is a triangular space. The introduction of the botulinum into this treatment has improved many patients. See, as you know, you know already, the botulinum is produced by Clostridium botulinum. These toxins are injected into thyroarytenoid muscle for adductor spasmodic dysphonia, thyroarytenoid. And diseases are injected into the posterior cricoarytenoid, which is the main element here, in case of abductor spasmodic finding. Abductor spasmodic dysphonia, we inject into the posterior cricoarytenoid. In cases of adductor, as you all know, this is the main culprit is the thyroarytenoid and interarytenoid. This botulinum toxin is directly injected into the muscles. Of course, we should know that the effect of this botulinum is very short in duration, and the action of the effect of this botulinum starts at or around 72 hours after that, and we have to repeat this injection every 3 months for this patient. That is one problem. We have to repeat it every 3 months. How the botulinum acts here? It causes chemical denervation by slicing fusion protein SNAP or syntaxin, synaptoprovine, and thus blocking the release of acetylcholine at the synaptic junction. You all know acetylcholine is the main thing which released at the synaptic junction. This is blocked by this botulinum so that the spasms will be controlled. This is contraindicated botulinum in cases of pregnancy, in cases of aminoglycosides usage, and also in cases of myasthenia gravis. Next, you should know about the puberphonia. This is also one of the tough problem and very common you come across in the ENTOP. Whenever the other names, the synonyms which people will use is the mutational falsetto voice or functional falsetto voice. Here what happened, there is a failure to change from high-pitched voice, which is seen in the children, to a low-pitched, as in adults at puberty in voice. Puberphonia is morely seen in the voice. As you know, the children will have a high-pitched voice, which is almost equal to the female voice. It won't turn into the low-pitched one in the adult age. Here, when we examine the physical and sexual developments of the child are normal, it is seen in boys who feel more emotionally immature and insecure, and those who fix much with mothers. When the mother more close to the mother, these people, these children, they have a more of puberphonia. Until puberty, the larynx dimensions are same in male and female, which you already know. Puberphonia, childhood voice, as I already told you, the higher pitched one, it is equal to a little female voice. After puberty, male larynx grows rapidly. The size of the larynx in the male grows rapidly and increases in the length of rama glottis. Anterior-posterior length of the rama glottis slowly increased in the male more. The vocal cords lengthen, which brings change in the character of male voice. When the vocal cords become more length, they get a change in the male voice. This voice becomes the adult with a low pitch voice. They have a harsh voice, which is a characteristic low pitch voice in the males in the adult age. This is a hyperkinetic function and a spasm of main tensor cricothyroid muscle. You all know there is one muscle called cricothyroid. The hyperkinetic function and the spasm of this muscle, which is a main tensor for the cricothyroid problem, then these people will have a puberphonia. You all know the cricothyroid will, when it contracts, the length of the vocal cord is increased. These people, they suffer with a social, because it is a social stigma, and psychologically there is a lot impact on the child. Sometimes the children, they don't like to go to the school, they don't come into the conversation, they don't participate in any social activities. This is the main problem here, which has to be dealt with further. In this, the glottis, when you examine, it is a vowel in shape sometimes, or sometimes it is a elliptical. Puberphonia children, that means those who are coming into the adult age, the glottis is still vowel and elliptical. Vocal process closely, they come together, normal people, but here what happened? Vocal process closes partially, producing posterior triangle, which we call it as a mutational triangle. Seen normal in puberty, which is persistent abnormal. When vocal process closes partially, there is a posterior triangle forms, which is called the mutational triangle. This is seen normal in puberty, but its persistence in the adult age is a abnormal one. You understood? It should not persist in the adult age. Persistent is an abnormal in case in adult in puberphonia. See, there is one test called Guzman's pressure test. Guzman pressure test. Here, the patient, when you press the thyroid prominence in backward and downward direction, which relaxes the overstretched parts and a low tone voice can be produced. You compress the thyroid prominence, that is what you call Adam's apple, in a backward and downward direction. This compression relaxes the overstretched parts, then it produces low pitched sounds, low tone, which is seen in the adult patients mostly. The diagnosis of puberphonia mostly done in cases with stroboscopy. This is all the advancement of the phono surgeries and phono knowledge has come only after a stroboscopy invention. Stroboscopy, those who are specialized in phono surgeries, the stroboscopy gives a lot of information for us. This stroboscopy defines the vocal cord pathology with this persistence of mutational triangle in case of puberphonia in the adults. Radiology of the neck shows narrowing of the cricothyroids found there, and the treatment here normally what we do is the vocal rehabilitation and the re-education will solve the pitch to normal speech therapy. See, many patients, even in Visakhapatnam, we are having good speech therapists who can manage the puberphonia to bring it to the mostly 95% of puberphonias are managed even on Visakhapatnam, Andhra Pradesh also. And here you need the psychological counseling, that is very much important. Then only when they come out of the psychological stress, then only they come to the normal in puberphonia. There is one word what we call hot potato voice. This word is used more in your books. This is what we call muffled voice. Hot potato voice means muffled voice. This is also 1-2 marks. Sometimes we get a question. This is a muffled voice, other name. This is produced due to obstruction in the glottal tract from the epiglottis to the vocal cords. From the epiglottis or the base of the tongue, from the base of the tongue itself, up to the vocal cords, whenever there is a block, you will get this hot potato voice. And you can give some examples like peritonsillitis with abscess, or hypertrophied lingual tonsil, or lingual thyroid, the another condition. Growth of the posterior 1/3 of the tongue also can give hot potato voice. Valvular cysts You know, the vallicula means a space, deep space between the median and the lateral glossoepiglottic folds. And there is cysts are there. These can produce hot potato voice and acute epiglottitis, which we discussed in the inflammations. This also can give hot potato voice, and also the epiglottic malignancies. Retropharyngeal abscess, that is another condition where you will find the hot potato voice. These are all because obstruction in the glottal tract from the tongue to the epiglottis, aryepiglottic fold. Then you should know about two things, what you call rhinolalia aperta and rhinolalia classa. These are also 2 mark question commonly it will come. It is a rhinolalia aperta means it is a hypernasal voice. Hypernasal voice, the nasal sound is produced more in the production. The words which have little nasal resonance are resonated more through the nose and nasopharynx. The words which you say has to resonate. See, if you say na, it has to resonate at this level. But when there is a defect, the na will be more resonance will be seen. See, that's why we ask the patient mostly is to say nana. When you say the nana, but aperta will follow, say na, 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 like that. The patient will utter. This shows there is a defect in the speech which we call rhinolalia aperta. We see in the more of cleft palate common. The defect is a failure of the nasopharynx to cut off from the oropharynx and abnormal communication between the oral and nasal cavities. This causes a rhinolalia aperta. Another one is called the rhinolalia classa. Rhinolalia classa, some words, rhinolalia aperta, rhinolalia classa. Whenever you test rhinolalia classa, we use this, rhinolalia aperta, we use more the pa word, papa. When you use the papa, the nasopharynx has to close. Instead of that, the nasopharynx or palate is open, then they get the pa like that sound. Pa. This is what many times we test rhinolalia aperta. Sorry, I'm confused. Rhinolalia aperta is tested by the papa and rhinolalia classa by the nana. Whenever you test the classa here, it is a hyponasal voice. Na should be, sound should go through the nose. When there is obstruction in the nasal airway from the nose to the nasopharynx, then this resonance will not occur. Those words like M, N, ing, when you ask the patient to utter, there will be hyponasal will be there. This is called rhinolalia classa. Hope you have understood. Got that confusion. Rhinolalia classa is nasal obstruction produces the nasal twang, hyponasal. Rhinolalia aperta means there is a hypernasal valley, abnormal communication from the oral cavity into the nose can produce rhinolalia aperta. Because aperture itself, aperta, abnormal communication. You can remember it easily. So some example for hyponasality, nasal obstruction and nasopharyngeal obstruction. Common cold, any allergies of the nose, polypi, nasal growth, and also the adenoids. These adenoid, the patient will have a hyponasality, that is rhinolalia classa. Nasopharyngeal mass, this is also produced rhinolalia classa. Sometimes there is some people, the familial, they speak, it is a pattern of the speech in those people, familial speech pattern which we name. They will always speak with the hyponasality. Some people, they develop a habit of speaking with hyponasality. This is what we observe in some patients. Then hypernasality, that means more the sound instead of the soft palate and nose has to be blocked, but the sound goes into that area. One is the velatopharyngeal insufficiency, and there is a paralysis of the soft palate. Then you will get this hypernasality. There is one condition called congenital short soft palate paralysis or short soft palate. That means the patient will have a small soft palate, still, even it is closed, there is still the space is left posteriorly, which is allowing the air to enter into the nose. Congenital short soft palate. Submucosal fibrosis of the palate. And there is a submucous fibrosis involves the palate, soft palate, and this also can cause the restricted movement of the soft palate, which produce hypernasality, that is the rhinolalia aperta. Large nasopharynx, already I told you, cleft of the soft palate and also the hard palate. Post-adenoidectomy, whenever adenoid, when you remove, because the patient is adjusted to that obstruction, when you remove immediately post-operatively for about 1 month, normally these people will have a rhinolalia aperta. Oronasal fistula, whenever there is a communication from the oral cavity in the nose, then also this patient, they develop hypernasality, rhinolalia aperta speech. There also here familiar speech patterns are there, habitual speech pattern. This is another surgery. Nowadays we are doing more is the sleep apnea surgery, uvulo-palatopharyngeopexy, UP3, many people they call it. In these cases also, because we remove a soft palate, for a few days the patient may have the problem of hypernasality, which we have to tell in advance. Otherwise, the patient will curse you and he will fight with you. My voice is changed. Because particularly those who work with public and also the teachers and those are with the profession of voice users, you have to tell them that it takes few weeks to come into the normal position. That's why we should not overdo in sleep apnea surgery. Undo is better than overdo, because permanent hypernasality, which you cannot correct in the future. There is one condition called laryngeal vertigo. While you speak much, sometimes speaking, suddenly the patient go into a vertigo condition, a false sense of orientation. They will go into reeling sensation. This vertigo sensation is a temporary one, unconscious feeling following spasm of the vocal cords leading to glottic closure. And there is a vocal cord spasm. This leads to the glottic closure. It is more seen in the males. And whenever you ask the patient, they always do some cough because of the laryngeal paresthesia. There is paresthetic mucous membrane. These people, they continue do coughing while speech also. Intermittently they do coughing because of there is a paresthesia of the larynx, which irritates this and produces cough. It is seen in the chronic bronchitis patients and also the chronic pulmonary disease. Those who are suffering with a chronic bronchitis, chronic pulmonary diseases like bronchial asthma and all, these patients, whenever there is a vocal cord spasm, then automatically there is a little intake of air which in reverse goes to the reduction of the cardiac output, which reduces the cerebral inflow into the brain. This cerebral ischemia causes a sense of unconsciousness in these patients. They have a high, sharp inspiratory stridor sometimes due to spasm of the vocal cord. Because whenever they have vertigo, they will have a high, sharp inspiratory stridor. But it is a short time, not a persistent one. At the time of vertigo, the patient becomes pale, cyanotic, and they have some headache. they feel dizziness. Sometimes they complain a momentary loss of consciousness also. These patients, when you observe, they also, you will see some tremors, and some patients, even they say history of convulsions, and also the urinary incontinence. These tremors and convulsions, urinary incontinence, are absent in these patients. You have to differentiate this patient to that type of from the epilepsy. When you see the tremors, convulsions, and urinary incontinence, then you can exclude this laryngeal vertigo. You have to diagnose it as a epilepsy. Rapid recovery is present. Immediately it is a momentary loss of consciousness. Rapid recovery occurs. There is no specific treatment here. Only treat the underlying cause like bronchitis and all. Once the oxygenation is good, they don't get this vertigo. There is another condition called mogiphonia. This mogiphonia, it is a phonic spasm which is present here, and it is seen in the professional users, voice users like singers, speakers, and clergymen. Initially, the voice is normal. Later, the vocal cords get adducted, and the person cannot speak. First, they start speak. Suddenly, there is a block in the speak. Vocal rest and speech improvement by slowly by speech therapy also can relieve the problem. We have to give the psychoneurotic treatment for this condition. Yeah. It's more of psychoneurotic. The importance of speech therapy you should know. See, there is a small hemorrhage at the level of anterior two-thirds to the posterior, anterior one-third with at the junction of the anterior one-third with the posterior two-thirds of the vocal cord. But this is it has come to normal the speech therapy. The importance of speech therapy, everybody should know here. The vocal hygiene, the mouth breathing has to be avoided because the dry allergens they will enter. Smoking and fumes has to be avoided, and vigorous exercise, spicy food that also has to be avoided. We should not strain the facial muscles and laryngeal muscles during the speech. Voice rest, and whenever you ask the patient voice rest, many people they say I am taking rest, sir, but I am not able to. I am giving voice rest, and I am speaking with a low voice whisper. Whisper needs more struggle to correct. It takes more laryngeal muscle struggle. That's why whenever you advise voice rest, ask the patient not to do the whisper even. Gastroesophageal reflux disease has to be controlled. No speech when there is a noise. When there is a noise, automatically you will increase your loudness or intensity of speech, which goes to the vocal abuse. No forced cough, and don't clear the throat regularly, and don't scream. Avoid alcohol. Aspirin and antihistaminics also has a role which produces dryness, and that produces a clearing of the throat. Increase the fluid intake, and voice rest is very, very important. Absolute voice rest, where you have to suggest the patient paper and pen only. See here, there is a small vocal nodules. It is treated gradually. Every 2 weeks, this picture is taken, and we have found the vocal cords has come to the normal. You should know how the speech therapy will help. Next, we have to discuss the next of the larynx is the benign and malignant lesions of the larynx. We start to discuss two conditions. Later, we will discuss in the next class. Here, I wanted to show one condition, what we call split or bifid epiglottis. The epiglottis has been split into it is a congenital defect which we have come across here. You all should know the rinky space. The space deep to the thin mucosa of the two vocal cords is called the Rinky space. It has no direct lymphatic drainage. The superficial layer of lamina propria is having three layers. The superficial layer consists of loose fibrous tissue. This part is called the Rinky space. The intermediate and deep layers of lamina propria consist of elastic and collagenous fibers, which forms the vocal ligament. This space is a subepithelial space already we discussed. It extends from the anterior commissure to the vocal process behind and medial free border to lateral border of the vocal cord, the extension of the Rinky space. Anteriorly, from the anterior commissure to the vocal process, laterally, medial border to the free border, that is medial free border to the lateral border of vocal cord. Chronically, irreversibly swollen vocal cords are present. It is one stage of chronic laryngitis. There is a collection of edema fluid in the Rinky space, how the vocal cords appears in these patients. The etiology, mostly vocal abuse and smoking. We see in this type of Rinky edema, 40 to 60 years of the age patients. Men and women are equally affected. You see, this is the Rinky edema. The other names for Rinky edema are called polypoid vocal cord, polypoid degeneration or hypertrophy of the vocal cord, chordal polyposis, and polypoid carditis. Rinky edema is a 4-mark question. The symptoms here, there is a deepening of the pitch of the voice in women, and when they speak, it sounds like men. Whenever occurs in the women, when they speak, the sound comes like a man. Gruffness of the voice and effortful speaking, they take more effort, choking episodes are present. It is many times bilateral, 60 to 80% is bilateral. When you examine, you see grayish or yellowish color with a prominent vessels over that. Sometimes it may be associated with leukoplakia. It is graded into 4 grades, and there is only edema, marginal edema. We call it as a grade 1. There is obvious sessile swelling thrown over the vocalis muscle. It is a grade 2. Large bag-like swelling with fluid. Large bag-like swelling filled with fluid. We call it as a grade 3. And there is a partial obstruction where the medial borders are in contact with almost its length. We call it as a grade 4. See here, difference between here, left vocal cord is more involved, and right vocal cord you are having a thin. Sometimes it is unilaterally more and may not be bilaterally equally edematous. Management by reassurance and vocal hygiene, we have to assure the patient it will come to normal. Once they see the pictures, nowadays we are taking more of video endoscopes. Whenever you give the picture, they worry more, thinking that I am having some carcinoma. That's why you have to assure the patient, and we have to control the vocal hygiene. You have to tell the patient minimally they have to talk. They should not use a loud voice, or time also has to be limitedly they have to speak. And the main part here is the smoking cessation. Ask the patient, they have to stop. Otherwise, they won't. They'll go on to smoke, because it is very difficult to make the patient stop the smoking. You tell them that is a pre-malignant one, even though it is not. But you can tell the patient pre-malignant so that he will stop the smoking. And malignance only the word, patient will get afraid of that word. Then hypothyroidism. This is another condition which has to be excluded whenever you diagnose as a voice defects and also the Rinky edema. And another one is the upper airway infections also has to be treated. Then the next comes is the voice therapy. What are the surgeries we do here? And surgical indications are whenever a rinky edema associated with a leukoplakia. The other indication, when there is a gross edema causing choking, the stridor, then also we have to do surgical excision. When the pitch elevation of the voice is the main requirement, some professional voice users, the pitch elevation is not there, then their main requirement, they want a good pitch, then also we have to do the surgical procedures here. The phonosurgery is one of the another branch evolving from the ENT now. We are having so many branches going phonosurgeries, lateral skull base, anterior skull base, endoscopic surgery. This is all microscopic, video endoscopic, sinus surgeries. These are all different branches. What are the principles of surgery here? We have to reduce the bulk of the mucosa mainly. Reduce the bulk of the mucosa. While doing this, while attaining the reduction of the bulk of the mucosa, you should see that there is the mucosal edge should be very straight, because those two edges will come together, produce the voice. Don't damage the mucosal edge and reduce the lateral part of that by doing a micro dissections. Avoid damage to the tooth and exposure of the underlying vocal ligament. Whenever you damage the vocal ligament, if you dig more into the vocal cords, automatically you will go into the deep and middle layer of the lamina propria. When you damage that vocal ligament, the patient will have a permanent voice defect. This is very important doing phonosurgery in the celebrities. We have a friend that he does a lot of work to celebrities in the Bombay, one of our friends. Microlaryngeal stripping is a main thing. What we name that surgical technique is called microlaryngeal stripping. We have to strip the vocal cord, but not the medial edge. Medial edge is very, very important because they come together. And here we have to stress the patient regarding the smoking stoppage and also the speech therapy. Once you treat the patient with these surgeries, don't give him an impression. Again, he can go for the same type of speeches. You should you send the patient to the speech therapist so that they will advise and advise the person. There is one recent surgery has come, reduction glattoplasties. Here what will happen, the myxomatous material from the superficial lamina propria is aspirated and epithelial edges are opposed. See, they go into the depth of the rinky space, micro dissection, and this myxomatous material is slowly absorbed, not at all damaging the mucosa and also the medial edge of the vocal cords. There is another condition what you should know is a contact ulcer. The other word for contact ulcer is called kissing ulcer. These are all benign lesions which we have discussed in the previous information also. The polyps and also the vocal nodules. You can discuss in the benign masses also. Also, you can put these contact ulcers and all into the inflammatory category also, because chronic laryngitis producing these conditions. These results because of the inflammation also. That's why we put both. The benign lesions which come, whenever discussed, we come with the vocal nodules and vocal polyps, and this rinky edema, and also the inflammatory category of the larynx. It is called a kissing ulcer. It is present at the junction of the anterior 2/3 with the posterior 1/3. Here you have to remember, contact ulcers comes at the junction of anterior 2/3 and the posterior 1/3 of the vocal cord. Why it occurs here? Because the vocal process of arytenoids hammer against each other in this area. Because at the junction of anterior 2/3 with the posterior 1/3, we are having a vocal process of the arytenoid. That's why these ulcers, because of continuous trauma, they occur here only. Then at the same time in these patients, now recent studies are telling this pharyngo-laryngo gastroesophageal reflux disease also to be addressed. This is one condition which was not there when we were studying, but now because of this reflux, when you sleep, acid contents from the stomach, without knowing, they will come in the night sleep into the oral cavity near the larynx and hypopharynx. These and also if they come more, they come into the oral cavity. Mostly laryngeal area, post-cricoid area, and all the pyriform fossa, these fluids will come. And these will give burn that mucosa, and the patient will have symptoms like hoarseness of the voice, constant desire to clear the throat. They feel they wanted to clear whenever they want to speak. They will say, "I want to." They will clear the throat, and pain in the throat. Sometimes because there is ulceration at that level, some people they may complain of pain in the throat. Treatment is by the voice rest. Ask the patient to go for a voice rest. Whenever there is an inflammation more, you can give the antibiotic for a while. But analgesic and voice rest mostly cures this condition. Thank you. Next, we'll discuss ventilators on the next.